All right, everyone. Welcome. It's time now for everybody's favorite way to share survey factoids. It's a knockoff of America's favorite survey-based game show and the most entertaining way to spend a Friday afternoon that's work-related. It's Friendly Feud. Here are your hosts, Jeff Bontrager and Eli Boone.
Well, welcome everybody. Welcome everybody, and thank you for being here. And welcome to those of you who are joining us on the live stream today. You are, in fact, in the right place for the 2019 Colorado Health Access Survey Results Rendezvous. My name's Jeff Bontrager, and I serve as the principal investigator on the Colorado Health Access Survey.
And hey everybody, thanks so much for being here today. My name is Eli Boone. I'm a policy analyst at CHI and program manager for the 2019 Colorado Health Access Survey.
And we are really excited to share with you more hot off the press findings from the 2019 Colorado Health Access Survey, which we fondly refer to as the CHAS. The CHAS is the foremost data source on healthcare coverage, access, and social factors related to health of Coloradans.
Now, some of you may remember we released our initial findings from the 2019 CHAS earlier this fall. Some of you may have even been there. But we got a lot of questions from stakeholders across the state, things that they wanted us to dive deeper into. So we've been busy this fall with our statisticians, our writers, our analysts, taking a deeper dive into those findings that we're going to share with you here today.
And we're going to be sharing with you a number of policy insights that the data inform. Many of these policy insights will discuss policies that we have discussed at this conference, Hot Issues in Health. But we're also going to be featuring a couple stories of people behind the numbers of the CHAS, as well as ways in which the CHAS can be used to inform policy implementation and policy decisions. So there is quite a bit of data that we will be presenting with you today. We're just going to be skimming the surface, though, of the Colorado Health Access Survey. There is a lot more information that will be included in the CHAS storybooks that everybody will get a copy of at the very end of this presentation. So make sure not to leave without getting a copy of the storybook. We will have a question and answer period at the end of this session. So please jot down your questions and we will be sure to get them answered at the end of the session. And then also, I just wanted to note that we'll be sharing some pretty serious findings from the CHAS, as well as some findings to celebrate. But we also recognize that this is a Friday afternoon. You've made the trek to the Tech Center to be here, and we want to have a little bit of fun with this too. So in that spirit, we would like to play our first round of Friendly Feud, and let's welcome up our teams.
Alrighty, this team loves research and evaluation and everything in between. Their hobbies include comparing confidence intervals, timing themselves on the New York Times crossword puzzle, and developing colorful graphics accessible to a wide variety of audiences. They chose their team color because it's the color of the vitamin-packed arugula, all the way from the west side of the CHI offices. Please welcome the Green Team!
Woo! Hey, welcome. Hey, thanks for being here. You, great to meet you.
Okay, the opposing team enjoys composing briefs about policy, blogs about policy, tweets about policy, and poetry about policy. They enjoy long walks together to the state capitol, statistical models, comparing premium increases, and facilitating groups of stakeholders to achieve established objectives. They are named after the sweet, sweet citrus treat, all the way from the east side of the CHA offices, the Orange Team!
Hey, Jasmine, thanks for being here. Spencer, great to meet you. Lindsay. All right, welcome to our first round of Friendly Feud and to our two teams. We're going to start with our first question. So team captains, come on down. Just go ahead and shake hands. There we go. We'll keep it friendly. What's that? Oh, thanks, Michelle. We're good. All right, first round of Friendly Feud. First question. You both ready?
Ready.
Ready.
Okay. The 2019 CHAS underwent a major change from being a survey where most respondents completed it by phone to one where most respondents completed the survey online. Top 7 answers are correctly on the screens. Now, we asked a non-scientific sample of people the following question. What was the reason for changing the CHAS from a phone-based survey? Alec.
People don't have a landline anymore.
Okay, great answer. Let's see what the survey says. There it is, decline of landlines. Great job. All right, Jasmine, your turn. Same question to you.
People are answering cell phone calls from unknown numbers.
Okay, not answering cell phone calls from unknown numbers. Survey says, there it is. All right, orange team won the first face-off. Let's see if the rest of the team can complete the board. We're gonna need the mic. Thanks so much. And what's your name?
Hi, I'm Spencer.
Hey, Spencer, thanks for the help. All right, Spencer, same question to you. What was one of the reasons for changing the CHAS to an online survey?
People are watching too many cat videos, Eli.
All right, you feel pretty good about the answer?
Yes, I feel good.
Okay, let's see. Too many cat videos on the phone. Survey says? Oh. There it is. Okay. So sorry, Spencer. Yeah. All right, next person. What's your name?
Hi, I'm Lindsay.
Hi, Lindsay. Thanks for playing. Okay, same question to you.
The expense?
The expense. Let's see if the
Yeah.
expense is on the board. Survey says?
All right, nice.
Expense. Okay. If you're paying attention, you might know what the next answer is. Audience, we want to turn it over to you now. You just saw one of the other answers, but too many robocalls. You got it, all right. So we want to hear what are the other reasons, and just like that other survey show that we're kind of ripping off right now, we want you to shout out the answers as they appear on the board. So what else? Length of the survey. Okay. Anybody else? What's that? Response rates. Yep. Phone surveys, lower response rate. Anybody else? We'll take one more. Try out technology. Okay, let's see what the board says. We've got too many robocalls. What else? Federal regulations. You ready? Call blocking technology. Surveys are annoying. Okay, great job to our first round of Friendly Feud.
Okay. I just had a microphone malfunction here. Excuse me while I get this set. Okay, well, let's give our green and orange teams a round of applause. Thank you very much to our green and orange teams. We will have you back up here in a second. So that round of Friendly Feud just talked about how the CHAS moved from a largely phone-based survey to a largely online survey. But what actually is the Colorado Health Access Survey? Well, the CHAS is a randomly selected survey of 10,000 Colorado households. They are sent an invitation in the mail to their household and then invited to complete the survey either online or by calling up an 800 number. We administered the survey in both English and Spanish, and this year it was administered between February and June. It is administered every other year, so this year actually we're celebrating the 10th anniversary of the Colorado Health Access Survey. The data are sampled by the 21 health statistics regions. These are regions that were developed by our state health department for planning and research purposes. You'll see those regions outlined in some of the findings and the maps that we have for you today. And then the data are statistically weighted to be representative of the entire state's population. As I mentioned before, the CHAS is a wealth of data. We're just going to be skimming the surface today, but it has information not only on health care coverage, but also health care access, barriers to care, mental health care, substance use disorder, advanced directives. And this year we added a couple new questions related to the social factors that we know influence health in terms of housing and hunger and the unfair treatment in the medical system. So we'll be going over some of those findings as well. None of this would be possible without the generous support of our sponsors, the Colorado Trust and the Colorado Health Foundation. And I also wanted to point out and give a shout out as well to the Colorado Office of Behavioral Health and the Colorado Department of Healthcare Policy and Financing, which sponsored items on the 2019 CHAS. But this is a community asset that is available for everybody to use, and we'll be talking more about that later. So with that, I'm going to hand it over to Eli to outline the insights that we gained from the CHAS.
Thanks, Jeff. Oh, sure. So some insights from the CHAS. Like I said, we're going to build off that first September launch we did and provide some additional policy insights. First, we're going to talk about coverage. We'll explore what the CHAS further has to tell us about access and affordability. We'll dive into mental health care as well as oral health care across the state. And as Jeff mentioned, we have some new social factors data, and we're really excited to share things like housing, what food security looks like across the state. And we're also going to end with diving into unfair treatment that Coloradans experience in the medical setting. So diving right into the data, our first insight has to do with coverage, where we've called the theme Still Waters Run Deep. Now, the Still Waters Run Deep theme has to do with the uninsured rate that didn't change. That was a main takeaway at our September launch. But what we're convinced of is that there are critical underlying market dynamics happening. So a question for the audience. We said that the uninsured rate didn't change, but does anybody know, for one of these soft t-shirts, what the uninsured rate is? We'll just raise the hands right here. 6.5%. Great job.
Congratulations.
So here we can see where Coloradans received their health insurance and the change between 2017 and 2019. As we just heard, 6.5% is the uninsured rate. You can see that on the right side in the red. Now, between 2017 and 2019, we saw some other changes as well, namely an uptick in employer-sponsored insurance, or ESI. And along with that came a commensurate decrease in programs like Medicare and Medicaid in the individual market. Now, still waters run deep. And while we've seen a change in where Coloradans get their health insurance, what the CHAS allows us to do is dive deeper into the still waters between that 6.5% uninsured that hasn't changed, where we can dive into some specific populations. And we're noticing a concerning trend. And it's specific with children. Now, we've seen the uninsured rate for children increase over the past few iterations of the CHAS. But when you break this out by race and ethnicity, a concerning trend starts to emerge. Now, here on the chart, you can see the percent of uninsured Colorado children by race and ethnicity. And the purple is Hispanic and Latinx children in Colorado. The green are non-Hispanic white children. And you can see the uninsured rate hovers between 2.5 and 4% since 2015. And that trend continues for non-Hispanic white children. But the same isn't true for Hispanic or Latinx children. The rate goes from 2.4% uninsured in 2017, more than tripling to 7.9% in 2019. And as Jeff shared, new in the 2019 CHAS Storybook are stories profiling the Coloradans that are behind this profound data. And I'm going to read off my script here because I want to get this right. But this is a story from safety net clinics across Colorado that work directly with these populations. And in 2017, Anahi Sebastian, the lead medical receptionist at Every Child Pediatrics Denver Clinic, started noticing something is changing. Fewer kids were enrolled in Medicaid when they were coming in the door to receive care, and more kids were uninsured. And it turns out that this was happening at other Every Child Pediatrics clinics as well, and at safety net clinics all across the state. And now the CHAS gives us numbers to confirm what the safety net workers are seeing. This year, the CHAS has found an increase in the children's uninsured rate. And as you saw when we dug deeper into the numbers, we found an increase that was in Hispanic and Latinx children specifically, begging the question, what's going on? Well, for one thing, it could be the paperwork that's required to enroll in public programs like Medicare and CHIP. But we talked to Ross Brooks of Mountain Family Health Center. Some of you may know him. And he posits an additional idea. He says that anti-immigrant rhetoric stemming from the White House is making families scared to sign up for Medicaid, even for U.S. citizen children. And Ross says that the fear hasn't gone away over time. It's gotten worse. And we just want to add that it's not about whether someone has or doesn't have insurance that makes it expensive. Another new question on the 2019 CHAS was about surprise billing. We saw that 31% of all Coloradans had a surprise medical bill in 2019. And another profile included in the storybook shares some of the stories of a family whose unexpected medical bills totaled over $1 million. And we could look at what the CHAS informs about this intersection of coverage, affordability, and access.
One of the big takeaways from the CHAS findings this year was that there appeared to be a backslide on some of the gains that we've made around affordability on both care and coverage. And it's why we call our storybook Progress in Peril. In other words, Colorado still has a ways to go in realizing the affordable part of the Affordable Care Act. So we did a deeper dive, and some interesting patterns emerged from the data when we examined both cost and access by different insurance sources. And it made us wonder whether there is a recipe to addressing some of these issues. For example, we hear a lot about providers not taking Medicaid coverage. The CHAS shows us that there are comparable issues actually on the commercial side as well with individual coverage. So what this graph is showing is the percentage of Coloradans who indicated that they did not get needed care because the doctor would not accept their insurance. About 20% of people enrolled in Medicaid and about 20% of people enrolled in the individual market indicated that this had been their experience in the past 12 months. That compares to about 7 to 8% enrolled in Medicare or enrolled in employer-sponsored insurance. Now, why is there this discrepancy? Well, there's various hypotheses. I mean, first is on the individual side, this might be a result of carriers narrowing their networks of providers and there just being fewer providers available to take that individual insurance. On the Medicaid side, we hear a lot about providers not taking Medicaid because of reimbursement issues, among a host of other factors. But what's interesting is that it's not merely a function of public coverage or private coverage, as we have examples of relatively good access for Medicare, which is, of course, is a public program, and for employer-sponsored insurance on the commercial side. Now, we realize as well that these insurance programs serve very different populations too, and we want to make that clear. But a similar pattern emerges when we look at perceived cost from the survey as well. So the first graph there on the left shows the percentage of people who reported foregoing needed specialist care or a prescription drug due to cost. You'll see that once again, Medicare and employer-sponsored insurance, you have a lower percentage of people reporting that they had foregone specialist care or a prescription drug due to cost compared to Medicaid or individual coverage. So we think that there might be other factors going on here, that it's not just a matter of public versus private. And Eli is going to walk through how policy discussions, both on the public and the private side, are aimed at addressing these issues as well as figuring out what that recipe is.
Thanks, Jeff. So like Jeff said,
Oh, boy.
Sorry about that.
That's my dog.
This is Walter. Right back where we were. Okay. It's funny, we were joking about some way to work Walter into the presentation. So we
Check.
figured out a way to make it work. Yeah. So as Jeff was telling us, it's not about whether your insurance is public or private. That means Coloradans will report fewer barriers to care. CHAS data is telling us that there are some other factors at play. Now, Democratic presidential candidates, you can see them here on the screen, largely talk about expanding public coverage. This stems from ideas like Medicare for All, the public option, or some other plan. And speaking of candidates, some of us heard from Yamiche Alcindor earlier today. She's moderating the next Democratic candidate debate, but we have a still from a previous debate. We want to challenge somebody from the audience to see if they can stand up, come up to one of these mics if you're comfortable, and name from left to right the Democratic candidates on the screen. And we'll toss in another t-shirt for you.
Here, I can take the mic to them.
Thanks, Jeff.
Volunteer. Okay,
got some
I
people
see
over
a
here.
volunteer over here.
We know it's a
I
small
think
picture.
Dr.
So.
Douglas had his hand up first.
So let's see, left to right, Cory Booker, it looks like Tulsi Gabbard and Amy Klobuchar and
Nice.
Mayor Buttigieg, Elizabeth Warren and Vice President Biden and Senator Sanders and Kamala Harris and John Yang. And I guess that's Tom Steyer.
All right. Let's give him a round of applause. Great job.
Congratulations.
Excellent work. So these candidates are pretty well known. One common thing between them as well is that their healthcare platforms largely focus on expanding that public coverage. So the question we want to ask today is, are there ways to capitalize on those successes of Medicare that Jeff showed us earlier when it comes to a broader public expansion? And when we look at Colorado, the conversation is largely focused on expanding the private market, which makes the state unique. The state, when it comes to expanding the private market, has the most jurisdiction specifically over the individual market. And we see this most blatantly with public option. Draws mainly on the regulatory power of the Division of Insurance to make health insurance more competitive, set affordability standards, and ensure that consumers are the ones who realize these savings. Now, from the data, we know that the individual market struggles in terms of things like access and affordability. But there may be lessons from the employer-sponsored market to address some of these challenges. One thing the employer-sponsored market has going for it is that it negotiates pretty well on behalf of their members, and that leads to lower prices. An innovation on the individual market and the small group market as well is Peak Health Alliance, which assumes this negotiation responsibility on behalf of enrollees, with local providers leading to more affordable care for locals and residents on the individual market and small group market as well. One other thing employer-sponsored markets tend to do is they have less risk when it comes to insuring them. In reinsurance, while it doesn't change the risk pool, it does make the individual market less risky to insure. And we've seen some success, whereas lowered premiums across the state by 20%. And the CHAS is a critical tool in creating a baseline and measuring the impact of how Coloradans interact with these new innovations, both at the state and federal level, and will be moving forward. But there are plenty of other applications for the CHAS as well. And there's no better way to learn about those applications than by playing our favorite Friday afternoon game show, Friendly Feud.
Okay, let's welcome back our teams for Friendly Feud. Yes. Next question. Come on, green team. Come on, orange team. Okay, next two contestants.
Uh-oh.
Okay, so Spencer, we met you earlier. What's your name?
Hi, I'm Nina.
Okay, welcome, Nina.
Thank you.
Second question here. So the CHAS is a community asset, and the data are available free of charge. Top 8 answers are on the board. We asked participants at the September CHAS launch events ways in which they use the data in their work. What do you think they said? Spencer.
Grant writing.
Grant writing. Use the data for grant writing. Okay, let's see if it's on the board. There it is. And the ding should be coming. Okay, Nina, your turn.
I'm going to go with needs assessments.
Okay, needs assessments. Let's see. And needs assessments are up there. Okay. So, green team, it's up to you. Mike. Okay. What's your name?
Hi, I'm Hugh, and I must say it's an honor to be here, Jeffrey.
Welcome, Hugh.
Thank you, thank you.
Okay. Same question to you.
I'm going to go with use the data for graduate school research.
Okay, let's see, using data for graduate school research. Okay, there we go. Okay, Alec, back to you.
I'm going to say telemarketing at free cruise sweepstakes.
Okay. Telemarketing for a free cruise sweepstakes. Okay, let's see if that's on the board. Survey says? Oh, sorry. Okay. So the question, of course, is how do people use the CHAS? So audience, let's hear a couple answers from you. Anybody? Policy making, legislation. What's that? Funding allocation. Evaluation. Okay, let's see if those are up on the board here. So first is organizational priority setting. Advocacy. Community or state level decision making. Yes, there you go. Targeted education. And evaluation. Yes, okay. Thank you to our teams. We'll hear from you in a bit.
All right, so now we're going to explore what the CHAS can tell us when it comes to exploring discussions around mental health in Colorado. And specifically, we want to focus on parity and Colorado's progress towards achieving it. First, I've got some bad news. More Coloradans are not getting needed mental health or substance use disorder than they ever have been since we started measuring it in 2013. You can see it here on this graph. In the red are Coloradans who reported not getting needed mental health services, and in the blue are Coloradans who reported not getting needed substance use disorder services. You can see that both increased since 2017. And I'm going to ask you to hold on to that 13.5% as we're going to revisit it in 1 second. Oh, and that 2.3%, while it is a small percentage, it represents nearly 100,000 Coloradans across the state. So this data does matter, even when it's a small percent. Now, parity laws are one way that lawmakers can ensure that Coloradans are getting the same level of behavioral health services as for physical care. And that's how parity is defined. One approach, it's one approach that can address the data that we saw in the last chart. Increase access by making it more comparable to physical care. And discussions around parity have been happening for decades. We saw in 1996, Congress passed the Mental Health Parity Act. 2008 saw the Mental Health Parity and Addiction Equity Act, which added substance use disorder treatment into the definition. 2010, as we know, the passage of the Affordable Care Act. Parity was one of the many focuses of this monumental legislation. And in 2019, and specific to Colorado, we passed House Bill 1269, the Behavioral Health Care Coverage Modernization Act, which requires private insurers and Medicaid to cover substance use disorder and mental health services at the same level as physical care and report out how they're complying with state and federal law. So remember that 13.5%. This data comes from that 13.5%, and of that 13.5%, these are the percentage of Coloradans who did not get needed mental health care because of cost. And we've separated out by insurance type because we know that there are unique levers that influence each insurance type when it comes to accessing and cost as an issue. So this is how the CHAS can inform our progress towards parity. And what's remarkable about this graph is that no matter the type of insurance, we've seen a decrease since 2013. There have been some fluctuations, but overall, it's going down. And we know that there's a lot that goes into these data, and that there are a lot of factors that contribute to this downward trend. But we feel pretty confident that efforts towards parity are likely one.
So our next story is about a family some of you may know, Doug and Susan McCarthy of Durango. And Doug is a researcher for the Commonwealth Fund, and he's actually here with us today. 12 years ago, Doug and Susan adopted a baby boy who had been through trauma in the womb. And today he has some serious social and emotional challenges. This really showed up when their son's trusted therapist moved away, and just as he was starting middle school. Now, Doug is a national expert on health systems, but when it came to navigating the local system, he was at a loss. One morning, Doug had to call the crisis hotline because of his son's behavior, and he was shocked when they told him that they have no services for kids, and he should call the county sheriff instead. So Doug and Susan took out their retirement savings to pay for a private educational consultant who found a therapeutic boarding school for their son. Now, they know that not everybody has the resources to do this, so in a way they feel lucky. We chose to tell their story in the CHAS storybook today because it shows how complicated mental health care access is. It's not just about finding a provider, it's about schools and law enforcement, wraparound systems, and the knowledge to navigate it all. All of these systems have to work together, and frankly, they're not working together. We'd like to thank Doug for sharing his story with all of us, and it's one more little victory in the fight against stigma and increasing healthcare access. So we just talked about cost as a barrier to a couple different types of care, particularly mental health care. But let's talk about one other type of care that often gets overlooked, and that is oral health care. One thing we found in the CHAS that is a reason for celebration is that we saw an increase overall in the percentage of Coloradans who indicated that they had dental coverage, and an increase in the percentage of Coloradans who said that they had seen a dentist or a dental hygienist in the past 12 months. Today we're going to be talking about some of the barriers to oral health care. So we found that in the CHAS that many rural areas of the state, in particular communities in the northwest corner of Colorado, had higher percentages of people who said that they had foregone dental care due to cost. So this map is broken out by those 21 health statistics regions that I mentioned to you before. In the northwest corner of the state, I believe for Health Statistics Region 12, it's upwards of about 32% of residents who indicated that they had foregone needed dental care due to cost. This compares to about 20% at the state level, and then the lowest HSR, the one with the best score, is 13.5% in Douglas County, Health Statistics Region 3. The takeaway is that rural communities report greater barriers to accessing dental care. So in relation to policy, one of the solutions that the Polis administration is discussing is whether Colorado should create a new class of dental professional called a dental therapist. And how many people have heard of dental therapy? A couple, okay. So with dental therapy, a dental therapist can do many common preventive and restorative procedures that a dentist does and works under the direction of a dentist. And this is an idea that was first tried in Alaska in 2003, and it's been picked up by a couple states since then. But the big idea is that dental therapists, with the proper training and oversight, can more easily provide care in remote communities at a lower cost than a dentist. So the CHAS data suggests that there might be areas of the state, in particular those write your examples on those postcards. You can do it now. Borrow a pen from your neighbor if you don't have one. And leave it with a CHI staffer as you leave. For those of you who are joining on the live stream, you can do a couple of things. You can send us an email to chas@coloradohealthinstitute.org. You can tweet about how you use the CHAS using this Twitter handle and hashtag. But you can also you can share your examples in many different ways. And what we're going to do is actually hold a drawing, so drum roll please, for a customized CHAS presentation for your office. So if that's not incentive enough, I don't know what is. But please go ahead and fill out those cards as to how you use the CHAS or how you think the data can inform improving the health of Coloradans. You will also be receiving a survey today after the CHAS session that we would like for you to complete about the session. So please make sure that you look for that in your inbox and take some time to complete that to help us continue to share the value and the impact of the Colorado Health Access Survey. With that, I'm going to invite Eli back on stage to talk about some of the social factors data.
Thanks, Jeff. And we'll give you a second to finish up your postcards. All right, back to our regularly scheduled programming. So as you heard in the beginning of our presentation, the 2019 CHAS was redesigned to start to key in to some of these social factors that directly impact our overall health. And as many of us know and have heard at the conference, that one of these is housing. The quality of your home directly impacts your health, but so does its affordability. So does how stable it is, and so does how accessible it is depending on where you live. So the 2019 CHAS asked respondents that if in any time in the next 2 months moving forward, you were concerned over having stable housing, that you would have somewhere to live. And if respondents said yes to this question, we consider them to be housing unstable. And what we found is a incredibly profound link between having unstable housing and overall health that comes directly from the CHAS data. Of those with unstable housing, 44.1% report poor general health, in stark contrast to the 12.3% with stable housing that also report poor general health. Similar trend with mental health. Those with unstable housing report poor mental health at a rate that's nearly half, and a rate that's more than 3 times the rate for those with stable housing. And it's also true for oral health as well, where 46.8% of Coloradans with unstable housing are reporting poor oral health. Again, in stark contrast to the 16% of Coloradans with stable housing. And across the state, we know housing instability is about 6.7%. One other question that the CHAS asks is if respondents own or rent where they live. And we can see that this burden of being housing unstable isn't fair between renters and owners. 2.4% of those who own their home are considered housing unstable, according to the 2019 CHAS. This is 1 in 6 Coloradans, or 16.3% of the state, for renters who are considered housing unstable. And we can map this and see where housing instability by renters are across the state. Here in the map, you see the percentage of renters experiencing housing instability in 2019. And the lowest rate is in HSR 5 on the Eastern Plains. But the highest rate, where our eyes are pretty naturally drawn, is in HSR 12, where 42.7% of renters, nearly half of those who rent in HSR 12, are housing unstable, meaning that they may be concerned in the next 2 months that they don't have some place to live. And we know that this area of the state is expensive. It's the resort areas in the mountains. But this is a profound link when you connect it back to that other data about rates of poor general health, oral health, and mental health. Now, some good news. The Colorado legislature is working to address some of these issues during the 2019 session. This was in the form of 4 bills sought to increase renter protections in one part of the housing process. Now, Senate Bill 225, which would have allowed local governments to have a say in stabilizing rent, ultimately failed. But what this does show us is that elected officials are taking our housing very seriously. And our next insight, similar to housing, is around food security. where the CHAS was designed to measure food access, is a factor that impacts our overall health as well. Now, the CHAS asks respondents, over the last 12 months, was there ever a time where you spent less money than you felt you should because you didn't have enough money for food? And this is how that data looks mapped across the state. Now, most prevalent areas are in the southeast and southwest corners of the state, where nearly 1 in 5, the highest percentage is 19.1%, nearly 1 in 5 Coloradans go with eating less food. Across the state, this looks like 9.6%, which translates to over 500,000 Coloradans. And these CHAS findings are coming amid a time where the state and private funders are looking in to address this issue as well. This is the blueprint, Colorado's Plan to End Hunger, or the Colorado Blueprint to End Hunger. Now, it's designed to address all Coloradans, but specifically calls out seniors and children as vulnerable populations. It's easy to see why, but what the CHAS can tell us is that it points to another vulnerable age range. CHAS data show us that Coloradans aged 19 to 29 are the most likely to not eat as much as they think they should because they don't have enough money. Now, these young adults, oftentimes called young invincibles, maybe this new data from the CHAS shows that they may be facing more hardships than we previously thought. And we're going to share one last story with you from the 2019 CHAS storybook. It comes from the town of Los Animas in southeastern Colorado. Now, I got to meet with the Commissioner Felix earlier today, and it was great talking to him and to put a face behind the story in the chart pack. Los Animas Helping Hands has served as an on-call food pantry to help out local people whenever they needed it. But the last summer, the needs were so great that they had to set up a regular Monday food pantry in a garage behind the county courthouse. They're now serving 700 people a month, which is a lot considering the county has a population of less than 6,000. So we have CHAS data to bear this out. In southeastern Colorado, 18% of people said that they ate less than they felt they should at some point in the past year because they couldn't afford food. And that's almost double the state average. And this matters a lot for population health, which we also explore in the storybook. So be sure to check it out. And a couple takeaways from ideas and conversations we've had with Coloradans who work to fight hunger. First, it's that food access problems are prominent in rural areas. Oftentimes, the people who grow our food are the same ones who aren't getting enough of it to eat themselves. Second, these local food pantries, like the one in Los Animas, are doing all they can, but there's clearly a systemic issue, and there should be a systemic answer. The CHAS shows us this strong correlation between food security and health. And if we're looking to improve the health system and save money, one of the best ways is by keeping people healthy so they don't need medical care. And it's obvious to us that food security is an important part of that work. I'm going to turn it over to Jeff for our last story on unfair treatment. Sorry.
So the final set of data that we're going to show you is perhaps the most sobering. We know that systemic discrimination can be a factor influencing a person's physical and mental health. And to get at it, we added a few new questions to the survey that asked adults about experiences of unfair treatment when seeking medical care over a person's lifetime. Now, Michelle Leek, our CEO, yesterday talked about places where we can celebrate. I think one thing we can celebrate is the fact that most Coloradans don't experience, or they report not experiencing, unfair treatment in the medical system. But what we did find was also a wake-up call. About 15%, or 1 in 6 Coloradans, Colorado adults, I should say, reported sometimes or often receiving unfair treatment when getting medical care. Now, these were survey items that we borrowed from the California Health Interview Survey. And when I looked at California's results, the latest that were available were from 2017. It was about 11% of Californians who experienced unfair treatment, either sometimes or often. And so we're at about 15%, those yellow and orange bars there. So to draw more of a direct connection to the health impacts of unfair treatment, we asked about the stress that was involved with unfair treatment. So not surprisingly, almost all of those who indicated that they had sometimes or often been treated unfairly when getting medical care indicated that they had experienced some degree of stress. So about 94% indicated this. This equals about 578,000 Coloradans. And most of those indicated that the stress, it was either somewhat or extremely stressful when they experienced this unfair treatment. So the stress obviously can have a real impact on mental and physical health. We also asked people not only the stress that they experienced, but also the reasons why they thought that they experienced unfair treatment. The top answers are listed here, and those top answers include age, gender, disability, and race or skin color. But significant numbers of people reported the other reasons as well that we have here, including sexual orientation, ancestry or national origin, and the way you speak English. Each one of these we are planning to do a deeper dive into to look at specific groups of people, specific groups of Coloradans, and which reasons they most are likely to report when they say that they experienced this unfair treatment. But it was surprising to us that age was actually the #1 reason. Audience, what age group do you think was the most likely to indicate unfair treatment of any reason, or of any type? Yes, over there. The over 65? Yeah, any other guesses? 35. So we were surprised to see that it was actually ages 18 to 29 who reported the highest rates of unfair treatment when seeking health care, so at about 19.3%, and it goes progressively down from there to about 11.8% for those who were 65 and over. You may be picking up on a theme of these findings today, which is that the data highlights some of the stresses that young adults are facing with food insecurity, uninsurance, and perceived unfair treatment in the healthcare system. And this theme is something that we would like to dive into more. So these questions about unfair treatment are actually about people's experiences in the healthcare system over their lifetime when they actually sought care. But we were also curious as to whether unfair treatment or consequences served as a barrier to people even seeking health care in the first place. And what we found was that about 283,000 people, it's about 5% of the population, indicated that they had foregone needed care because they were concerned about unfair treatment or consequences of getting care. We added this question after discussions with a number of stakeholders about concerns that we talked about earlier in terms of anti-immigrant sentiment producing a barrier to people seeking health care that they need. This has implications certainly for medical schools and training programs, hospitals, providers, advocates, those who are involved in workforce policy in understanding the reasons why people forego needed care. Now, I'm going to just review our headlines here quickly, and then we're going to open it up to the question and answer period. So first, Eli talked about coverage. We call this still waters run deep, where we saw no change in the uninsured rate of 6.5%, but we think that that masks some underlying dynamics within the market. And we did see some concerning signs, particularly among children who identify as Hispanic or Latinx in terms of the increase in their uninsured rate. The second is access and affordability. So when we look at different coverage types broken out by cost and by access to care metrics, we see this trend of Some coverage sources, both on the public side and on the private side, perform better than others. Mental health care. Eli talked about parity and how we've seen a gradual decline over the years in terms of the percentage of people who said that they didn't get needed mental health care, citing cost as that reason. And then oral health care. There was some reasons to celebrate with oral health care, but we also talked about some of the disparities in rural Colorado, as we did with housing in terms of some of the rural areas of Colorado, particularly with that renter-owner divide. And finally, with food insecurity, young adults are most likely to report the food insecurity, and then unfair treatment in the healthcare system in terms of the stress that that involves and the reasons that people cite for that unfair treatment. So with that, let's see, we've got Chrissy who has the mic. We're going to open it up for questions now. Okay, there's a question here and a question there. Let's wait for the mic. Oh, sorry.
Yeah, hi.
Go ahead. And then we'll
John
go to
Douglas,
Marty.
2 questions. This is always fantastic. So first of all, thanks to CHI and your supporters for making this continuously available. This is really a huge resource for certainly those of us in public health. One question is about the increase in, I think it was uninsured Hispanic kids, and the big hunch that this has got to do with the climate of the times. Realizing that this is a survey that's now done online, not by phone, are there any methodologies underway that you're aware of to try to quantitate that hunch?
You know, we have been approached by a number of safety net organizations who are seeing on the front lines that are seeing an increase in uninsured volume and a decrease in Medicaid, as Eli alluded to with the first story that we talked about. I have a hunch that the survey data may not have caught up yet with the data that is coming from actual providers that are working on the front lines. But what I would like to do is figure out a way to use some of those data from the providers that are actually serving patients to kind of verify that, because there's a lot of hypotheses happening right now about why we're seeing the decline in Medicaid, the increase in uninsured. The anti-immigrant rhetoric is one of those hypotheses. There's a number of others. But I've talked to a number of people at this conference over the past 2 days that are very interested in the same, in doing this further exploration too. So the short answer is I think that it will take a couple of triangulating a couple of different data sources to be able to get at that story.
Right. And then as long as I've still got the mic, do you have any insights as to what unfairness might mean? For example, has California done anything to kind of unpack that, to figure out what sort of perceptions are happening that make people feel they've been treated unfairly?
Yeah. Eli, if you want to chime in, you certainly can. I do know that on the California survey, they have added some questions specifically about unfair treatment due to a person's race or ethnicity that dives a little bit deeper into that. On the CHAS, we don't know the nature of the unfair treatment. That could be something that we could explore in future surveys. Anything you would add?
Yeah, it's certainly a serious issue, so we'd like to learn more about it. The CHAS does capture reasons they perceive to have been treated unfairly over their entire lifetime, but what exactly and how exactly the respondent defines unfair treatment is sort of hard to tell.
Yeah. So the next question up here to Marty, and then we'll go to Lisa.
Yes, on the housing instability, did you have any data for the those experiencing homelessness, either chronically or intermittently?
Unfortunately, that is a limitation of the CHAS in terms of understanding homelessness. Since this was a survey that was sampled by household address, we're missing the homeless population. So they will not be included in this particular survey. But again, I think it takes using some of the other data sources that are available, such as the point in time homelessness count to be able to kind of get at that story. So our housing insecurity is probably an undercount because it does not reflect the experiences of those who may not have a home. Yeah, good question. Thank you. Lisa.
I wanted to thank you for the friendly feud. I thought that for those of us who aren't data experts, it was a great way to really enliven the conversation. So thank you for all the participants. So I really appreciate the addition of the social determinants that you've incorporated related to housing and food security. And I'm interested in the findings in the southeast corner of the state and whether you did any deeper dive related to demographics of those families that are we, if we're looking at individuals, families, children, older adults, any particular thing of note there in that analysis?
Do you want to say anything about that?
Yeah, I'd say not yet, right? Certainly interested in the data. We saw that 18% of the people in that part of the state are food insecure, but that's exactly what we want to do with this data moving into 2020. So stay tuned for more, but you're asking the right questions.
Well, and we are happy to answer information requests to be able to run particular analyses if you're interested in a certain geographic area or a certain demographic group. Plus, I should also say, I was going to say this later, but today we are unveiling all of the suite of materials that will be available free of charge on CHI's website in terms of Excel workbooks that can be downloaded. There's all the regional data as well as data. We have regional profiles, the whole storybook, this presentation, all of that will be up on CHI's website. But it's certainly, we do want to look at some of those demographic groups by geography, assuming that we have enough sample size to do that. Yeah, thanks. Yes?
Hi, this is Kelly Schultz from the DOI. I had a couple of questions based on, you said there were 10,000 individuals surveyed. Is that the total respondents or is that the total surveyed? Not counting a non-respondent rate. And then my other question was, how are you developing the weights that you then apply to the number of respondents? Where is that information coming from?
Yeah, so the 10,000 is completed surveys. So there's a lot of surveys that went unanswered. So it's 10,000 completed surveys, and then the second question was around the statistical weights. And we work with a survey firm called SSRS who helps develop our post-stratification weights. So it takes into account the populations that we have essentially oversampled. So we oversample by geographic region. We also oversample African Americans and Latinx populations too, as well as families with children. So all of those factors are taken into account when we develop those statistical weights to make them representative of the state. But good question, thanks. So I think we have time for maybe one more question, one or two more questions. There's one there, and I saw one back there. So.
Hi, thank you. I just have some questions about generational differences, expectations of what's enough, what's appropriate. I see huge differences from older patients and younger patients in what they consider is enough or appropriate or acceptable. So I wonder if there's some way that that was taken into consideration.
Are you referring specifically to the unfair treatment in the healthcare system?
Yes.
Okay, in regards to unfair treatment in the healthcare system. I think one thing we can do is look at those generational differences. We've started to do that. They weren't included here, but we can start to look at, okay, so younger adults versus older adults, what are the reasons that they cite for that unfair treatment? Now, we don't know exactly the nature of that unfair treatment, but we can also look at how they've answered some of the other questions. So for example, a question that we've had since 2009 on the survey is views on the healthcare system. You'll see this in the storybooks that you'll get today, is the percentage of people who say that the healthcare system is meeting their family's needs, or that is meeting all of Coloradans' needs. It would be interesting to look at how people who report unfair treatment in the healthcare system, whether that has a correlation with how they answered those questions. I'm not sure if that's getting exactly at your question, but in terms of expectations, we don't have questions that ask specifically about different types of treatments and their expectations from healthcare treatments. Do you have anything you would add?
No, it's a good question. And like we shared with the earlier question, it's hard to tell, right, how that respondent is defining unfair treatment. But certainly important feedback from the respondent anytime they say they've experienced unfair treatment, but certainly something that we plan to look more into in 2020.
Yeah, thanks for the question. I think there was one more in the back. Oh, are we at time? Okay, real quickly. Okay.
Hi, Rebecca Conway, Zim Consulting. For more information on unfair treatment, One Colorado has a great LGBTQ health assessment. My question is related to the mental health care. You included Medicaid recipients, employer, and individual insurance. How do Medicare recipients fare in accessing mental health care?
That's a great question, and I think we might break that down in the chart pack, but that'll be available on our website, I believe, in one of our Excel workbooks. If it's not, you can feel free to contact us. So real quickly, the CHAS data can help you in a number of different ways in terms of adapting to the changing healthcare landscape and measuring effectiveness of reform efforts in your community. As I mentioned, all of these resources, the Excel workbooks, this presentation, the storybook, the regional profiles, the public use data file will all be available, posted today on CHI's website here at coloradohealthinstitute.org. So the CHAS is a community asset, and to help illustrate that, we are going to bring up our teams for one last lightning round of Friendly Feud, followed by the drawing for the ultimate CHI door prize, which is the bike. Now, I think there will be a CHI-er, Beck, do you mind kind of circulating through the audience so that you can put your raffle tickets that you got at the door, if those of you who just came for this session, if you want to enter the raffle for the bicycle that we're going to be giving away here at the end. But let's bring up our teams again for the lightning round. Woo!
Please welcome to the stage our team captains, Jasmine Baines and Alec Williams.
All right, welcome back. So we flipped a coin, and our orange team is going to go first. So we're going to ask the green team captain to go into our soundproof chamber while Jasmine enters the lightning round. You hear us, Alec? Okay, so I'm going to grab the mic, and then Jasmine and I can get started. There we go. All right, Jasmine, we're going to give you 30 seconds to answer the questions. Are you ready?
I'm ready, Eli.
Okay. Question number 1. What is a top reason people give for lacking insurance?
Cost.
There it is. Okay. Where can people go to find the CHAS results?
CHI's website.
Nice. Question 3. What is one way people can download the CHAS data?
The public use data file.
Okay. What can you expect from CHI in 2020?
More in-depth issue briefs from the CHAS.
Excellent. Final question. Name one thing that gets moldy in the fridge.
Cottage cheese?
There it is. All right. Excellent work, Jasmine. We can tap Alec and have him play his round of the lightning round. Welcome back, Alec. All right, your turn. 30 seconds on the clock to answer these 5 questions. Are you ready?
I'm ready.
Okay, question number 1. What is a top reason people give for lacking insurance coverage?
Lost eligibility.
There it is. Question 2. Where can people go to find the CHAS results?
The free copy of the CHI storybook you got today.
Question 3. What is one way people can download the CHAS results?
Excel workbooks.
All right. What can you expect from CHI in 2020?
Ongoing data dissemination and answering information requests free of charge.
Great answer. Final question. Name one thing that gets moldy in the fridge.
Fish sticks.
You got it. Excellent work, Alec. You can take the mic with you. And this is incredible, folks. We've been playing this game a lot over the last 4 weeks. And for the 4th straight time, both teams have tied, which means everybody gets CHAS storybooks. Great job to both of our
Okay,
teams.
come on up here,
Great
teams.
job,
Yes,
Jasmine.
here we go.
Alec, here you go. Great job, Lindsay, Spencer. Excellent work. And so I think it's time for the much anticipated drawing for the ultimate door prize, the bike. So I'll ask Michelle, comes up on stage. Woohoo! A round of applause. Thanks, Michelle.
Thank you. How about a round of applause for the Friendly Feud?
Oh, you have a mic.
I now know what you guys have been doing in the boardroom for the last last week, and I had a little sneak preview, and you have come a long way. So, really nice work here on that Friday afternoon. This concludes everything from that CHI has to offer on December 5th and 6th, and we want to thank you all for being a part of that. You just did a really nice job connecting the data from the CHAS to the policy implications. I really appreciate that. I started yesterday with a plea to tap into expertise and think about blending expertise with crowdsourcing. And I think that you'll see at least an attempt to do that in the chart pack that you'll receive on your way out the door to bring to light the data and analysis through the stories of Coloradans throughout the state. I also have another plea for you, and that's to pay particular attention to your comment card, the postcard there. We're up against it in terms of trying to figure out how we continue to have CHAS as a community asset moving forward. It's not an insignificant undertaking, and it's resource and intensive in terms of the financial cost of that. We are uncertain about the future of the CHAS in terms of the funding in 2021 and beyond, and we think that the stories that you tell about how you use the CHAS as both an expert and as a crowdsourcer are going to be extremely important to the continuing legacy of the CHAS. So I ask you to take the postcards probably a little bit more seriously than you'd like to on a Friday afternoon, but it would be very helpful to us if you would do that. So thank you for attending everything. And now, does everyone, because this has happened in years past, and so like sometimes people don't get all the instructions when they need to get the instructions, did everyone submit their bicycle raffle ticket? Because if it's not in the bucket, you can't win. Okay, I'm just going to scan the room here. All right, everybody who wants to be in the bicycle raffle is in the bicycle raffle. Okay, it's Ashley Brown's birthday today. Where is the birthday girl? So we're going to ask her to do the honors of picking the lucky winner here. Take your time, Ashley. Oh, happy birthday. CHI, that was not your best effort. From the Community Health Partnership, it's Beth Jewell. Woo! All right. All right, thank you all so much. We'll see you next year.